It's my pleasure to introduce our new guidelines presentation. We have two speakers, Stephen and Levi. Welcome. And here's your mic when you're ready. It's on mute. Yeah, it's off. Okay. Stephen earned his doctorate from Touro College of Pharmacy in New York, New York, then completed 2 residencies, both in ambulatory care pharmacy, first at the Mayo Clinic in Rochester, Minnesota, and the second at Providence St. Peter Family Medicine in Olympia, Washington. He is now a preceptor for both the PGY1 and PGY2 pharmacy residencies at Providence and core faculty for the Chehalis Family Medicine Rural Track Medical Residency. He currently holds an associate professorship with Washington State University Pharmacy, Nursing, and Medical Schools, where he earned his expertise, where his areas of expertise focus on family medicine, addiction medicine, psychotropics, and interprofessional collaboration. Dr. Levi Lancaster received his Doctor of Pharmacy degree from University of Tennessee Health Science Center. He completed his PGY1 pharmacy practice residency at Providence St. Peter Hospital and then specialized in family medicine through his PGY2 residency in ambulatory care at Providence St. Peter Family Medicine. He is board certified in both pharmacotherapy and ambulatory care. He currently serves as the medical director of operations and faculty pharmacist for the medical residency program at the St. Peter Family Medicine in Olympia, Washington. His professional interests include preventative care, population health, diabetes, and dyslipidemia. Thank you both for being here.
Thank you. Yes, thanks for that introduction. Sorry that it was so many words between the two of us. This is an interesting moment in time because the last 2 years we've been presenting behind a screen. I'm actually wearing pants today, so this is we're going in the right direction. So today's presentation, Levi and I will be doing a bunch of new guidelines, and we're going to kind of sprinkle between some things, and some will build off of what Terry talked about this morning. And many kudos to her for reading journal articles which are not for the faint of heart, and trying to distill all that information into us in the 2 hours is rather challenging. Oh, thank you. Okay, I think so. There we go. Great. No disclosures for Levi or myself today. We're going to identify those practice guidelines that have been updated in the last year, discuss those updates and how they change practice, and then lastly, how it modifies our practice in relation to those actual guidelines. But first, we'll work on primary prevention because in October 2021, we had a pretty strong statement from the USPSTF on aspirin use. So we'll focus on that first. The question that comes to mind when aspirin data came out is, are we looking at primary or secondary prevention? So the scope of these next few slides is strictly primary prevention. And the difference between primary and secondary prevention would be the effort to prevent or delay the onset of ASCVD for primary, whereas secondary is the effort to treat known clinical ASCVD and to prevent or delay the onset of the manifestations of those diseases. Now, the examples are pretty telling. And on the far left-hand side under primary, it's severe primary hypercholesteremia greater than or equal to 190. That is classically confused with secondary because your LDL is so high. We're actually trying to prevent an event from happening. A high LDL does not mean you have overt ASCVD that you have to treat secondarily. And then patients with diabetes as well. We're kind of trained in, oh, they have diabetes, they need to be on a statin. We're focusing on primary prevention there, not secondary, because I haven't had an event yet. Underneath the secondary column, it's coronary heart disease, cerebrovascular disease, aortic atherosclerotic disease, and peripheral artery disease, and then some subsets within those. So again, we're focusing on primary prevention for our conversation today. And aspirin has had a storied career through this, and it's gaining less and less traction as these years go by. So for secondary prevention, hundreds of trials showing us the benefits of aspirin. For serious vascular events, also great evidence, MI, stroke, TIAs within that, and then CV death. As these years go on, we're seeing less and less benefit for primary prevention. We're going to take a walk through the history of this, going back to 2016, when the USPSTF came out and said, with the grade B, initiating low-dose aspirin for the use of primary prevention of cardiovascular disease and colorectal cancer in adults aged 50 to 59 who have a 10% or greater 10-year CVD risk, are not at increased risk for bleeding, have a life expectancy of at least 10 years, and are willing to take low-dose aspirin at least for 10 years. That was in 2016, level B recommendation, pretty solid. Between 2016 and now, we've had 3 different trials come out, ARRIVE, ASPREE, and ASCEND, all focusing on aspirin in the primary prevention setting. This is a collated batch of data for the CV, which is the 2 middle columns, and then major GI bleed on the right. So the far left-hand side is the name of those landmark trials. The things highlighted or bolded here are showing what is clinically and statistically significant for major GI bleed. So all 3 of these trials, when they came out, showed very little benefit for the CV component of aspirin. As you can imagine, as time has gone by, we have more people on statins. So the benefit to aspirin is dropping off because of that confounded evidence. But we're seeing this increased risk of GI bleeding associated with these patients as well. So just a very interesting dynamic of this teeter-totter being aspirin as the sole medication for reducing events. Throw statins in there, we're getting some gray evidence, very murky, and now we're seeing more GI bleeding with these patients just on aspirin alone. So 2019, ACC/AHA says with level of evidence A, low-dose aspirin might be considered for the primary prevention of ASCVD among select adults between the ages of 40 to 70, a little different than our USPSTF in 2016. And we still are holding on to this concept of if they're at low risk of bleeding, sure, let's give it a shot. We pooled that data between 2016 and 2019, and want to show the hazard ratio of the CV events favors aspirin versus no aspirin, and then compared to the GI bleeding component. So similar to that table with those 3 landmark trials, we're pulling all those together here. So the left-hand side, you see a few crossing that one, maybe making not statistical significance or clinical significance even for aspirin. But if you look on the far right-hand side for the GI bleeding, all well over there, favoring that aspirin causes bleeding. Nothing misconstrued here. GI bleeding is clear, still getting more and more gray for the CV side of things. So in 2021, USPSTF came out with this. Adults aged 40 to 59 years with 10% or greater 10-year cardiovascular risk, so that threshold 10% stayed the same. The decision to initiate low-dose aspirin use for the primary prevention of CVD in adults of that age who have a 10% or greater 10-year risk should be in an individual one. So this now has been downgraded to a grade C statement. Evidence indicates that the net benefit of aspirin use in this group is small. Persons who are not at increased risk of bleeding and are willing to take low-dose aspirin daily are more likely to benefit. And then adults age 60 years or older, grade level D. The USPSTF recommends against initiating low-dose aspirin use for the primary prevention of CVD. So we've seen a huge swing here in 5 years, and it's hard to keep up with this. And every time I talk to whether family at home or patients, I say, oh, I take my aspirin, I'm good. I'm like, well, I'm not sure you are anymore. We have too much information telling us that you might not be good. So we should be consistently reviewing our patients' medications and their comorbidities to make sure that risk for bleeding is not on the rise. So what does that mean for us? Aspirin on the decline. We have these confounded evidence with statins in the background. How does this impact the public's health? So beside the conversation that I just discussed, we need to talk about our use in statins and where do they lie for primary prevention. So the same batch of guidelines between USPSTF and ACC/AHA pull out the recommendations for the CVD risk. And so for adults age 40 to 75, clinicians should routinely assess traditional cardiovascular risk factors and calculate the ASCVD by using that cohort equation that we have online or your phone. The calculator is pretty seamless to use. And for those who remember Framingham risk scoring years ago, That is still very much a strong evidence component to how this data is calculated. And there's going to be some new scoring and some different types of objective data, which we'll talk about in a second, through coronary artery calcium scoring. But this is still one of the more objective ways we can help find which patients fall into the categories for needing statin therapy. Before we jump into statins, of course, we have our mainstay of treatment and lifestyle recommendations. And I keep this in my back pocket, not just to keep in my notes and copy and paste, but I want to make sure I have something objective for my patients to walk away with, talking about number of minutes needed to see a reduction in weight. I like to use this chart on the far left here for thinking about the intensity of the different activities someone may be doing. Oh, so what do you do for physical activity? Well, I walk to the mailbox every day. Well, that's not enough to really see a reduction in ASCVD events. We have to do more than that. So something objective that's tied to that for our patients is extremely helpful. And I will continue to talk about this with not just our residents, but our patients as well, describing preventative medicine versus treating a secondary prevention strategy here after an event. So the definition constantly comes up, wanting to make sure we're attacking it from the right angle. So staying in that line of primary prevention, this comes from the ACAHA. In the top left-hand corner, it goes from primary and then stratifies into age. So you have less than 20, 20 to 39, and then age 40 to 75. And after that, we're still leaning on the ASCVD risk calculator to help us make a decision after the age itself. Now, if you direct your gaze to the far right-hand side, other than age, we have a few other categories that fall for primary prevention. That LDL greater than or equal to 190, diabetes, age 40 to 75, needs a moderate intensity statin. The diabetes, age 40 to 75, do that risk assessment. And if it's high enough, we're going to choose a high intensity statin. Then once we get to grade greater than 75, it's a clinical assessment and that risk discussion. The most challenging part about this graph will be right at this bottom part here, the risk stratification between 5 to 20%. So less than 5% low risk, emphasize lifestyle. We're going to talk about the calorie restriction and exercise. As you move to the right, 5 to 7.4, very narrow window. We're still talking lifestyle, maybe moderate intensity statin, depending on their comorbidities. And as we go beyond to 7.5 to 20% and greater, we're looking at LDL reduction of at least 30% and then 50% for the high intensity class. So it's not a very easy answer every time. Oh, does this person need a statin? You have a few questions you have to ask yourself. What's their age? What's their ASCVD risk score? What are their comorbidities? And then using that to help drive your decision on the intensity of your statin. Now, of course, this is primary prevention. If it's secondary prevention, we throw this out the window. Everyone gets a high intensity statin if their LDL can tolerate it. But we're going to save that conversation for another day. When choosing between those statins, that can also pose a challenge because there are so many. But the only two that have the high intensity ability would be atorvastatin and rosuvastatin. And the rest fall into moderate intensity, and those lower doses would be low intensity. What's nice about atorva and rosuva is we have the 80 and the 40 of the two respectively. And if we're starting someone on those for high intensity, we can work on coming off of it or going down if they can't tolerate it. There's a school of thought that we should start someone on a low, moderate, or a low version of the high intensity and work with our ways up. That's not what the guidelines say. We should be starting at the highest intensity that is indicated for that patient. If they can't tolerate it, then we back down to the next one. If they can't tolerate the lower dose, then we switch over to a different statin. So knowing the properties of each of the statins is very important. So the ones that are hydrophilic, meaning less side effects, are pravastatin, rosuvastatin, and fluvastatin. Ones that last for 24 hours, doesn't matter what time you take them, atorva, rosuva, and prava. The least amount of drug interactions, prava and rosuva, and then the cheapest ones are the five there. Crestor has been generic for many years, and we have a question which I'll take in just a second. So now that it's generic and it's been out for a while, we should think about leaning more towards rosuvastatin because of this lower chance of having side effects because of the hydrophilicity of that agent. And if we're having someone that's statin intolerant that we can't even get through that cascade of prescribing, we're going to start with pravastatin instead. Low side effects, and still you can get to the moderate intensity version of it. There's a question that I'll take. Oh yeah, sure. That was for the exercise portion, I think here. Yes, let's see here. Oh, yeah, thank you. So the question is, what does MET stand for in this chart? This is the I forget the exact acronym name for it, and it's in my notes here. But essentially, it's how fast we're getting that heart rate up, and how quickly, and the vigorousness of the exercise itself. So if you get to the MET of greater than or equal to 6, you are getting to, in theory, your target heart rate, where you need to be to have that as a cardiovascular exercise. So the higher the METs, the higher the fat burning that you're going to have, and the bigger caloric drop you'll have from that activity as well. Thank you, Doug. If you have any questions, please add more to the queue. Anything else, Mylin? Awesome, thank you. Here's another version of looking at the statins when we're comparing them. This is from up to date on the far left-hand side. But this helps me make a decision on what percent of LDL reduction I need in my patient, and even adds a little bit more value to help making that decision with the patient. Why am I choosing Rasuva or Atorva? Well, you fell into this category. We need your LDL to be here. And I'm not going to get that with these other agents. So it just helps add a little more gumption to your decision making there. On the far right-hand side, this compares all the agents that have LDL lowering. And one that's not on this chart that Terry talked about is inclisiran. And the reason I did not include it is we're still waiting for the CV trials for that agent. The PCSK9s, we have that. Plenty of data on cardiovascular events. We don't have it yet for inclisiran. So I don't have that on this chart yet. Once that comes out, then I'll feel more comfortable putting that on as what percent of LDL lowering it'll have. After your statins, your next question would be, where do we fall with Zetia? And from 2002 to 2015, we've had quite the change between Zetia data that's come out. And we've gone from, yes, you can use it, to, well, we don't really see much benefit, to, oh, if it's paired with a statin, we'll see benefit. And so for the secondary prevention guidelines, after your lifestyle and statin, you would consider Zetia, and after Zetia, PCSK9. In the next 1 to 2 years, we'll see what do we do after that with bempedoic acid and inclisiran coming out. This is the newest wrinkle to objective data to help with primary prevention, and it is coronary artery calcium scoring. It is an actual test. I think it's most comparable to like a DEXA for T-scores for osteoporosis, where you can see how much calcified parts of our arteries are there. So the scoring goes from 0 to 1 to 99 to greater to 100. This has come to be quite popular in a lot of cardiovascular clinics because they're trying to find other more objective, clear ways to say, oh yes, you are at risk for having an event. So for our patients who fall into this primary prevention category, where their LDL remains high despite statins, despite Zetias, despite the lifestyle treatment, we may order this test to see if they need any further LDL reduction lowering. I want to compare the two. It's going to come up. Which one's better, ASCVD or CAC? So on this left-hand side, it's the 10-year ASCVD risk based by that scoring. On the right-hand side, it is the 10-year risk by just ASCVD. We'll start on the left-hand one. So let's look at the far right column of the left chart where CAC is greater than or equal to 100. So greater than or equal to 100 is high risk. Patient needs a statin. When we ran that population and gave them an ASCVD score, 16.4% of that bundle had an ASCVD risk of less than 5%. So a bit more sensitive, meaning the 64 and the 19% remaining that are 5 to 20, greater than 20% ASCVD fell into a high risk group. Let's flip it and compare it to those who had an ASCVD score of greater than or equal to 20%. So that's on the far right-hand side in the second chart. 32% of those that had greater than or equal to 20% ASCVD risk on the calculator had a CAC score of 0, meaning we are inappropriately treating people with statins based on that compared to the CAC score. So I think we're going to see a clinical shift in the next few years here of people ordering a CAC to help make these decisions for our patients who fall into that gray zone specifically. So some summary statements for primary prevention. Aspirin continues to lose traction, and the recommendation is being constantly downgraded by our AHA and ACC and USPSTF. For our folk who fall into that range that may have benefit, that 40 to 59, if they're refusing a statin, an aspirin might be a good choice for them. They're having some benefit with their, as we can assume their GI bleeding risk may be low because they're younger. What happens for those group of people that are in their 40s that have been on aspirin for at least 10 years? It is safe to continue the aspirin because they've been on it for that 10-year threshold where they're going to see benefit. Statins for primary prevention, we should still be using our ASCVD risk calculator to help us decide. If you find a unique patient that needs a CAC, we can order that, send them to cardiovascular, they can get that done. And we are constantly reviewing the primary versus secondary prevention here. So my thought process is primary prevention. I'm looking at their comorbidities. I'm going to calculate the ASCVD. If it's secondary, I'm going right to my high intensity statin. I'm making an LDL go for that patient. Once they're on a statin, we're going to follow up with that LDL level to make sure they're reaching their appropriate goal. If they're not at goal, we should be intensifying therapy. If everything is still unclear, you could consider your calcium arteries scoring tool. When it comes to monitoring for statins, you can check a lipid panel as early as 12 weeks in starting just to make sure we're headed in the right direction. Coupling that with those lifestyle changes as well. Lipid panel yearly for those that are on a statin, and other things you want to check would be your hypertension profile, A1Cs, and thyroid stimulating hormone to make sure there's not anything else going on. So if you don't mind, Mylin, I have my first question on Lecture Panda. And we'll do 2 cases after. So the first question on Lecture Panda is, aspirin is proven to be beneficial for primary prevention in comparison to statins. Okay. I like seeing that second bar graph go further and further up. More people are choosing false. And that statement is indeed false. There's a yes, like yeah, excited. All right. Yeah, I'm excited. Yeah, aspirin is on the decline. And again, I'm not saying that we shouldn't use it. I like it for that patient population of 40 to 59 who won't try a statin. Hey, I'm too young. I don't want to be on something for LDL, but you see that ASCVD risk on the rise. Aspirin's a good bet for you because they can probably take it for 10 years to see that benefit from that initial statement from USPSTF in 2016. Let's go through 2 cases. JR is a 32-year-old female with history of type 2 diabetes, hypertension, depression, diabetic nephropathy. She admits that she eats a well-balanced diet, including protein. She's good about limiting carbohydrates. She's married with 1 child. She is currently not pregnant and is unsure if she would like to become pregnant in the future. Would you recommend initiating a statin in JR? Let's take a second. Of all her labs up there on the left, you have a 32-year-old female with type 2 diabetes. And Mylin, if you don't mind telling me if anyone says anything in the chat about it. And I'm happy to take some ideas here. And if anyone has a question about it or wants to further inquire, happy to share what I can. Beautiful. Okay, let's expand upon that. Now, who wrote that? Hey, thanks, Brian. Appreciate you responding. So Brian says no. Let's walk through our thought process. 32-year-old female, diabetes. We look at their lipid panel here. The LDL is, for the most part, normal, 98. Less than 100 would be a goal for someone that doesn't have overt other ASCVD comorbidities or risk factors. They have diabetes. So we're thinking, let's go to our primary prevention chart. This is not secondary prevention, it's primary prevention. To go to our chart and we notice that they're 32, and we can't go plug them into the ASCVD risk calculator. And that's the first move a lot of people want to go to. So they'll type in the age and say, well, you can't because they have to be 40 for that calculator to work. So we look at our far right, diabetes, but they don't fall into that category. Their LDL is 98. They don't fall into that category. So we're going to look right here underneath primary prevention at 20 to 39. Estimate lifetime risk. You can do that part, but you can't see the 10-year risk. And we're going to consider statin a family history of premature ASCVD. So we need to inquire with this patient about their family history to help us make a decision. If we start seeing that LDL tick up in the wrong direction, as we're following it, we should be on a yearly basis. We can help make more informed decisions. This is not a person I would order a coronary artery calcium test for, though. There's not enough gray area here. It's pretty black and white. Okay, second question. AH is a 45-year-old African-American male presenting today for follow-up with his PCP on hypertension that is treated with amlodipine. PCP believes they should start a statin, but the patient's afraid of statins because he heard some things from his friends. PCP comes to you to help determine if a statin should be started. PMH only significant for hypertension. Everyday smoker, BP was above goal, and we calculate that risk together to be 15%. So which of the following do you recommend? A, are we ordering a CAC? B, are we starting a low intensity statin? C, moderate intensity statin, or D, high intensity statin? And his LDL is 158, which helped us get to that score of 15%. Mylan, any love in the chat box? Okay. Anyone have any thoughts, concerns, questions about AH here? Okay. Okay, excellent. So we got here a moderate and high intensity statin. So we have this 45-year-old patient, which we can help calculate because they fall into that age. We got 15%. The only comorbidity here would be hypertension. We don't see diabetes. So we're falling again into this primary prevention pathway. So let's go back to our chart and take a look at where this 45-year-old may fall into. We're gonna go to the far right of that second line, age 40 to 75. LDLs between 70 and 189 and 158. Does not have diabetes. Everything checks out so far. A 10-year risk falls into that moderate, or the 7.5 to 19.9 intermediate risk. Moderate intensity statin. Pretty black and white for this particular patient. Now, if that LDL is greater than 190, we fall out of this pathway and we're on this far right-hand side and we're going high intensity statin from the start. Okay, thank you for those who participated. Any questions about primary prevention? That wraps up this section before we jump into CKD and the triple threat that is that. Yeah. Mm-hmm. Yeah. Mm-hmm. Sure. Yeah, thank you. Yeah, it definitely will. Yeah, thanks for your question. So we have this patient that comes to us and we are going by the chart saying moderate intensity statin. You know, why are we skipping over some other things? Talking about lifestyle factors. Why are we ruling that part out? Especially if we're starting a statin that could potentially cause metabolic components. So in short, I think it's just why. Is that a fair assessment of your question? Like, yeah. Yeah, so why aren't we focusing on hypertension and smoking? Sure. Yeah. Thank you. So I'm a bit short-sighted here because I was trying to speed up the actual question. I'm hoping that we all lean on lifestyle stuff first. We should be reducing smoking. We should be working on blood pressure. Now, the beauty of the ASCVD risk calculator, you can pick and choose which parts you're going to implement for your patient to see how far that risk decreases. So he's already on hypertension treatment. I agree, before necessarily knee-jerking and saying take a statin, it should be coupled with, if we work on your blood pressure, reduce your smoking, work on your weight, you might not need a statin. That's 100% accurate. And I agree with that. I would do that 10 out of 10 times first. If that patient came back to me after trying those therapies and everything is exactly the same, we'd be doing that patient a disservice by not offering something to reduce their LDL. Now, when it comes into race, specifically, yeah, African Americans are at a higher risk of that particular comorbidity. And let's talk about statin metabolics. I only have 2 more minutes on this, then I'm going to move on. The potential A1C increase with statin, depending on which one you talk about, is anywhere from 0.1 to 0.4. That can be sizable. The only one that hasn't shown that is pitavastatin. So if we're in that situation, pitavastatin, the one has been proven not to increase A1Cs or metabolic components. We have to weigh that risk. Do they have prediabetes? If I give them a statin, is that going to put them into full-blown diabetes? And where does that teeter-totter land? So great question. Everything else is normal, good to go. His A1C is 4.3. I still would be compelled after lifestyle implementation to offer a statin to this patient. Now, and I highlighted here the suggest the calcium artery scoring as well, because let's say that patient is on the fence. Yeah, I really don't believe a statin is going to help me. And maybe you're not as sure either. We could order that test and see, oh, you have a 99%, or you're falling into that 100 score, you have lots of calcified arteries. We should make this decision. And that's going to be a more helpful, objective way to make that call with your patient. But yeah, I appreciate it. And thank you for bringing up the consistent use of lifestyle measures for our patients. We should always lean on that first. Yeah, question in back. Mm-hmm. Sure. Question is, do you look at the family history? Yes. We should always be asking about family history, specifically, which is nice that they pull out in that flow chart, using family history as also a decision maker. Oh, I saw unfortunately, your father passed away at the age of 50 from a heart attack. Your LDL is at 158. You're near that age. We should start working on this now. Yeah, so always lean on family history. Yeah, front row. The question is PQA, right? Do they lean on ASCVD or CAC? They lean on ASCVD. Yeah, CAC is truly up and coming. No one has made a statement on that yet. Mm-hmm. Yes, Mylin. Any approximate cost on the CAC test? Levi and I were just having this conversation on the drive up this morning. The last time I looked at it from our cardiologist who ordered it was $200. I'm not saying that's a small amount of money, but I don't know what that cost would be to the patient, but that's the raw cost of doing the CAC. Well, thank you guys. Appreciate the questions. I have 20 minutes before I kick it off to Levi, so we're going to focus on this triple threat and the new guidelines between diabetes, CKD, and hypertension, and how these 3 things work with each other. It's actually become quite the public health push to talk about delaying the progression of CKD in patients because of the high cardiovascular risk events that have been coming along with it through these last few years. So we're going to break this triple threat down by pairing them together. And the crux of these 3 things would be ASCVD risk, albuminuria status, so ordering a microalbumin creatinine ratio, and then what are your disease state goals? So A1C, blood pressure, microalbumin creatinine. What are your goals for these patients? So if you can answer those three things, you're going to play very nicely with these three disease states at the same time. Now, historically, we're looking at a time change here. So from 2006 to 2008, which is that top part of the graph, and 2012 to 2014, the bottom part, we're looking at these parameters in our CKD patients and which percent of the patients experienced this intervention. So on the far left-hand side is your blood pressure goal, A1C. Are they using an ACE or an ARB? And then lastly, a statin in the age of 50. So, but compared to 2006 and 2008, we are arguably worse than where we were, despite the influx of data and the push for making sure we hit these parameters for our patients to delay cardiovascular events. We're not reaching our goals. We're not focusing on preventative medicine and hoping that people are taking things to protect their kidneys. So we'll focus on hypertension first, which is one of the causes of CKD. So your questions in hypertension go through several parameters. One is, what's their BP in general? What category do they fall into? And after you have that category, using their age to help create the blood pressure goal for that patient. The ACC-AHA pull in using the ASCVD risk calculator to also help make a decision for you. So you're going to check that as well. Those two things will couple together to make a strong decision on which medications you'll be using. And the last question that is not written in the guidelines, but this is what we should be doing, is checking that microalbumin creatinine ratio to make sure they are not on a CKD pathway while you're treating their hypertension. Now, why is that important? We'll get to that in a little bit. On the far left-hand side of this chart would be all the guidelines that we lean on: JNC 7, 8, European, ACC-AHA, ADA. And then as we move to the right, it's the population and then what that target blood pressure looks like on the far right-hand side. This has changed dramatically over the years. And this is all to say that we can't do a blanket blood pressure goal for everybody. It's impossible. Not everyone should just be less than 130/80. We have to focus on their comorbidities to help make that decision. And that's because we have so many guidelines that focus on those comorbidities. So on the left-hand side, I have the clinical condition. And then on the far right-hand side is that blood pressure goal. The newest one that I have here is underneath chronic kidney disease. So it's 1, 2, 3, 4, the fifth disease down. And the far right-hand side is less than 120. That's brand new, fresh out of evidence-based medicine. But using the comorbidities to help create the blood pressure goal is where you was part of that thought process. I want to answer that question first so I know how much blood pressure lowering I need to have for our patients. So within that guideline, they use the BP parameters, and we used to have stages years ago, and we had no stages in between. Now we're back to stages. So stage 1 and stage 2 are on the far right. And what's new with these guidelines is using the ASCVD risk score to help us make a decision. That's why it's part of that crux of the triple threat. We have to check the ASCVD risk. Not only do they have hypertension, but if they have hyperlipidemia, that's way more resistance and barriers to helping reduce blood pressure. So if they have that 10-year risk that's greater than 10%, we are going to consider adding blood pressure lowering therapy from the jump. Now, if they're in stage 2, they're greater than 140/90, you should still check the ASCVD risk score. That's going to help you make a decision, even though the guidelines don't specifically call that out. And they say you should be starting with blood pressure lowering medication from the jump as well. Now the question is, if they're greater than 140/90, do I start with 1 or 2 agents? ACC-AHA has that little cross next to it because they recommend starting with dual therapy if they're greater than 140/90. That's a big difference in prescribing patterns. It's not just lifestyle right away and as monotherapy. It's lifestyle coupled with blood pressure lowering medications very, very quickly. And I think the newest data that talks about mechanisms of action in milligrams helps us make this decision a little easier and almost a little bit more palatable to see a guideline say start with 2 meds. Don't worry about everything else. Go right to 2 meds. I think that's tough to really chew. But so the last few years, we've had these interesting data that comes out comparing different options of blood pressure medications. So in this particular chart, we're looking at changes in systolic blood pressure, and we're looking at adding different drugs. So it's not just increasing the dose of one, it's adding different mechanisms of action. So adding the mechanisms offers further blood pressure lowering as opposed to diminishing effects, which is once thought. That's evidence piece 1 to help us with that. This particular trial in 2020, Triumph, wanted to look at patients receiving treatment intensification in a triple pill, so 3 different mechanisms of action right off the bat, versus starting one, increasing the dose, starting another, increasing the dose. So triple pill is on the middle left and usual care is on the right. And we're looking at clinical inertia here. How long does it take to get them to goal by doing normal care, coming to visits, checking your blood pressure, adding one, increasing the dose, yada, yada, yada. The fixed dose combination had amlodipine, telmisartan, and chlorthalidone. Beautiful triple therapy here. You have calcium channel blocker, an ARB, and a thiazide diuretic, all very guideline driven. And we're seeing that we see less clinical inertia if we started someone on triple therapy right off the bat. So 3 mechanisms of action at lower doses versus 1 and intensifying therapy over visits. This trial from 2021 from Chow and colleagues, very similar, but we're looking at a quad pill now, which includes bisoprolol, irbesartan, and indapamide and amlodipine, so not typical blood pressure lowering agents. But the theory and the idea remains pretty similar here. We're looking at a monotherapy versus the quad pill. And you can see as you look on the far right-hand side that you're getting better blood pressure lowering with a low dose quad mechanism pill versus initial monotherapy in just an ARB. And this data, when the new ACC-AHA comes out in a few years, this is going to be part of it. It's going to help give us a streamlined idea of which medications to choose from. Now, the problem with the hypertension alone is not just the BP goal that we talked about. Can't have this blanket statement. We have to pull in the comorbidities. So we're going to look at diabetes and hypertension together here, and your thought process doesn't change. That same checklist of ideas you're going to continue: category, goal, what's their ASCVD status, what's their microalbumin creatinine ratio. But you're going to pull in now the diabetes portion. What's their A1C goal? And Levi's going to talk about some of the medications for that, but we're focusing on this together. This is a brand new flow chart that came out of the ADA 2022 guidelines in January, and it might look a bit daunting. What I like about this chart is they pull in those blood pressure goals from the ACC-AHA. So the far left says greater than 140/90, so that's stage 2. And they talk about which agents to start. And then they pull in albuminuria and coronary artery disease, so the ASCVD score. So that those thought processes are being shared amongst the comorbidity guidelines that we're using here. And as we go on, we're going to use those to help make decisions. So in this particular case, we'll focus on the far left-hand side of this chart and say they do have coronary artery disease or albuminuria. We're looking at starting an ACE or an ARB first. That's going to help protect their kidneys versus a calcium channel blocker or a thiazide diuretic, which would be preferred if they didn't have either of those, albuminuria or coronary artery disease. Then as we go on, we are adding those therapies because of the mechanisms of action. So nice flow chart here from the ADA. Really appreciate their thought process and them sharing that here. And we'll see this theme throughout many years to come as we see a different push for albuminuria being checked. So let's say they don't have hypertension, but they have diabetes and CKD. So we're going to carry that same thought process forward. We're checking an A1C. What's the severity of their CKD? And as you can imagine, the albuminuria status. What's nice about the albuminuria status is that it's a biomarker. There's no overt damage yet. So if you have micro or macro albuminuria, that's greater than 30 to 300 or greater than 300 respectively, that's your kidney actively working, hoping it doesn't turn into Swiss cheese soon, trying to help filter out more often. Once we see the creatinine change, now we have active kidney damage. So that's the importance of the microalbumin creatinine ratio. It's a biomarker that's going to tell us something's happening now, but we're not in dire need yet. So it really helps us focus on the preventative medicine side of things. We're going to see a lot of these patients who might live in this third quadrant here. So structural damage without loss of function, meaning their biomarker is positive, greater than 30, and their creatinine looks normal on the GFR or on a BMP. Now, this is important because the chicken or the egg situation of cardiovascular disease tied to CKD, diabetes, and hypertension, which one causes what, comes into play. So on this left-hand chart, it's your CKD diagnosis and your eGFR is on top and the microalbumin creatinine ratio is on the bottom. And it looks a bit opposite color because the top one, GFR, as the GFR goes lower, you have higher problems with cardiovascular disease and kidney function. And then microalbumin creatinine ratio, as you go higher, it gets more red on that side because you're having more CV problems and function problems. And on the far right-hand side, they combine the two, the GFR and the microalbumin creatinine ratio. And you can see everyone on this, as you go from the top left of the chart to the bottom right, gets more and more red, showing a higher risk of cardiovascular events. That ties into the hypertension, diabetes, and CKD. We're trying to attack this from many angles to help prevent any events happening across the board. So KDIGO in 2021 and 2022 partnered with the ADA and shared with us a nice strategy for these patients that have diabetes and hypertension. And we're going to focus on this far right-hand side. So CKD, I'm sorry, I said hypertension and diabetes, CKD plus diabetes. So we're looking at that particular picture, and this is where the SGLT2s come into play. They have diabetes and they have CKD. We're considering the ACE and ARB to help with their kidneys, and then we're also considering the SGLT2s. And Levi's going to talk about SGLT2s in terms of A1C and where it lands with metformin too. But I like that the KDIGO is making a stance on where SGLT2s come into therapy. They have diabetes, they have CKD. We should be thinking SGLT2s right away. In that same breath, they came out with this, this pictorial of lifestyle therapy and then what your first line therapy should be, and then additional therapy for treating diabetes. And SGLT2s are just continue to come up to the top there. All the heart failure trials that have come out, A1C not included, showed improvements and sustainability of kidney function. So this is helping KDIGO and ADA agree and lean on SGLT2s for preventing CKD progression. Now, the newest agent on the scene, Terry brought up today, and I really appreciated her plug for this drug, finerenone. The 2022 ADA guidelines said this statement, so I'd be remiss if we didn't talk about it. In patients with CKD who are at increased risk for cardiovascular events or CKD progression are unable to use an SGLT2, we'd like to use finerenone, which is a non-steroidal mineralocorticoid receptor antagonist, and it's recommended level A. So even though this medication has only been out for a year and change, level A recommendation from the ADA and KDIGO. And the three trials that helped to make this decision were Fidelio, which worked on endpoints for kidney health. Figaro was all cardiovascular with some specialty things within. And then Fidelity is the analysis of the two. So Terry talked about the Figaro trial earlier today, and we're going to focus on Fidelio, which is diabetes kidney disease. And what they're showing here is the reduction in GFR over time. And we're looking at placebo versus finerenone. And if you start placebo, how fast does that eGFR decline versus finerenone? And by month 6, we started seeing a little bit of a change. And by month 12, we really started to see a divergence between the two. And finerenone was statistically and clinically significant in delaying progression of CKD. We talked about biomarkers and active injury to the kidney. This is looking at eGFR, which would be that creatinine change, the actual damage to the kidney. So they took a second look at this, and from a perspective of microalbumin creatinine ratio, which would be the fourth line from the top here. And if you look to the right, you can see the confidence interval in the box around it is well below 1, favoring finerenone for helping your microalbumin creatinine ratio. Now, this is a very small sample size of this particular trial. This is not the 3,000 patients that they started with. So we don't have the overwhelming evidence saying this has to be done for this particular component. But this is a good precursor to the future data that's going to come out on why we're consider finerenone in these patients. So our last possible combination would be hypertension and CKD, and you're pulling in all the information we just shared. What are this? It's the same thought process. Category, goal, ASCVD, albuminuria, and then their blood pressure goal changes now. It's less than 120 for the CKD guidelines. And the first question that pops up for you would be, what's their microalbumin creatinine status? If they have albuminuria, we're going ACE-ARB. If they don't, we can consider thiazides and calcium channel blockers right off the bat. And the rest of this chart talks about what happens if you get to a point where you need to enhance therapy. As you can imagine, we're adding mechanisms, not milligrams. KDIGO, similarly with the ADA guidelines, partner with ACC, AHA, and then walks us through what happens when you start an ACE or an ARB in those patients. And what I like about this one, on the far right-hand side, they confirm what we've been practicing for years. What is a reasonable change in your kidney function before we discontinue the medication? And they agree and highlight that if it's a 30% change in your creatinine, if it's greater than that, we should be checking for other causes of AKI, correct volume depletion if that's the thing, reduce medications that could be causing it, work up renal artery stenosis. But the big take-home message here on the bottom right is reduce dose or stop the ACE-ARB at a last resort. So we don't have to have this knee-jerk reaction to stopping or reducing an ACE or an ARB if it doesn't pass that 30% change in their creatinine from baseline. That's the newest wrinkle to that one. So the combination of these agents for CKD, delaying of the progression, would be ACEs and ARBs for the hemodynamic component, SGLT2s if they have diabetes, at least at the beginning. And then this says steroidal, which would be spironolactone or eplerenone, and then the new one, finerenone, which helps with inflammation and fibrosis. So now we have another new cascade of prescribing for patients of CKD, which I know is not our favorite thing to do, right? You have heart failure, there's 10 meds you got to be on. ACS, 10 meds you got to be on. And now you have CKD at a minimum 3, just to help prevent your kidneys from worsening. So I created this chart to help us with this thought process. So on the left-hand side would be the agents or the class, and atop the right-hand x-axis is the disease states or the combinations of. So if someone has CKD, diabetes, and hypertension, we're considering all of these agents for them. Where the question marks lie for finerenone, we don't have a trial for finerenone and CKD alone. And we don't have it for CKD plus hypertension. It's just diabetic kidney disease. That's its very targeted, particular track for treatment for finerenone. So our summary and conclusions for this triple threat is making sure we order and document our BP category, our goal, their ASCVD status, and albuminuria. If you can have all those things done, it's going to help you make a very, very informed decision on which medications you're going to use for those respective disease states. And we are under ordering microalbumin creatinine ratio. That should be done for almost every patient that's coming into primary care. Once you have that blood pressure goal decided, look at their comorbidities to help with your prescribing patterns. For CKD, ACE or an ARB first, then adding an SGLT2 if needed. That's plus or minus diabetes. And the medication cascade for DKD, ACE, ARB, SGLT2, and then finerenone. And they can be on all 3 together. Very safe. And I have a few questions, Mylin, if you don't mind, on Lecture Panda. There's 2 on there that I want to ask. We'll do those first, and then I'll take any questions after that before Levi, or while Levi's getting ready. So microalbumin creatinine ratio should be ordered for these disease states. There's many answers here. Lecture Panda did not have the functionality for select all that apply or select all that apply. So I'm seeing overwhelming responses for yes, diabetes, for sure CKD, some for hyperlipidemia. I don't see any for hypertension yet. So for that particular question, the correct answer would have been everything but hyperlipidemia. If someone comes in just with high LDL, that is not an indication for ordering microalbumin creatinine ratio. But hypertension, diabetes, CKD, got to have a microalbumin creatinine ratio. The next question, Mylin, if you don't mind. This will also has multiple answers. What are the landmark trials for finerenone? Fidelity, Figaro, Fiddle, or Fidelio? Excellent. So the only one that wasn't was Fiddle. That's not a trial at all. That's a really mediocre instrument. Okay. Any questions while Levi's getting ready for me about CKD, hypertension, diabetes, finerenone, guideline changes? Yeah. Great questions. The question is, after you order the microalbumin creatinine ratio from the beginning, what do you do after that? Finerenone and Kadigo both recommend checking every year after that to make sure the kidneys are at a minimum, not worsening, and hopefully we're getting better. So the question that you want to supplement that with is, what's their GFR status? You want to make sure that's also taken a look at. Because if the biomarker is positive and their GFR is normal, you can check that yearly to make sure you're coming back with success with your ACEs and ARBs, SGLT2s, or finerenone. You can check it as early as 3 months with finerenone, as early as 6 months with SGLT2s, and with ACEs and ARBs, it takes about 6 months to see an actual impact on your microalbumin creatinine ratio. Mm-hmm. Correct. Yeah, so in our colleague's response here is, you might check it, but what do you do when you check it again? As more for your peace of mind and making sure we're not putting them in harm's way going forth. And like, you want to give as much data as possible to not progress that CKD. Thank you for asking. Yeah, one more, Mylin.
Yeah, I have a question that online from Lena. If a patient has been on aspirin for more than 10 years, do we continue it even after the patient turns 80? I heard something about taking it for more than 10 years, but missed the details.
Oh, sure. Yes, the question is length of or duration of therapy with aspirin. Once you're on it for beyond 10 years, you are, I'm using quotes here, guaranteed for the USPSTF to have the benefits of aspirin. Continuing beyond the age of 75 will then be a decision between you and the patient. USPSTF says if the GI bleed risk is higher, we should stop it for primary prevention. Anything else, like they have other problems, you can continue. For primary prevention, you'd stop it. Thank you. Thanks, Levi, for your patience. I'll turn this off.
Okay, thanks so much. Everybody can hear me okay? So please, questions can go into the chat if you have any, and then I'll leave some time at the end of each of my sections. I have 3 guidelines I'm going to be focusing on today. First is going to be sexually transmitted infections, which is a CDC update. Oh, there we go. Okay, so objectives here, just for your knowledge. So starting with prevention, right? An ounce of prevention. So there are several vaccines that we can use to help decrease the spread of some STIs. Hep A and Hep B should be pretty standard in kind of childhood vaccinations. However, if you have a patient that is an adult and has not received the Hep A and B vaccinations, strongly encourage them, especially if they're sexually active, because those are spread sexually. HPV vaccine, this is one of the changes that the guidelines just kind of coming in, lining up with other guidelines. The CDC kind of changed their age range. So HPV vaccine, when it was initially approved, was really for patients 11 or 12 years old. And that's still the preferred time to give the HPV vaccination. We've also seen it expanded from just women to also men, because men tend to be the carrier and kind of transmit it to women, although women are the ones that are more at risk for cancer associated with HPV. And so the age range has continued to get longer, so up to 26. But again, recommendation is really try to target 11, 12-year-old patients before they've started having sexual activity, because that's really where the risk of transmission is going to be greatest. It's kind of, the guidelines were very non-specific, talking about the shared clinical decision-making in patients that are older than 26, so up to 45 years old. And they really say shared clinical decision-making. And so for what I take from that is it a 28, 30, 35-year-old patient who has had limited sexual partners in their history? If so, they might actually benefit from still getting the HPV vaccine. However, if they've had several sexual partners by that time in their life, really the value of the vaccination, it isn't quite there. Some of these questions are awkward. It's not a really, comfortable thing to talk about, and you're going to run into pockets of patients. Some are going to be oversharers, and then some are going to be undersharers. And so just having some clinical questions to be able to ask them to help guide those conversations so that we don't have to get into the setting of having the conversation and struggling through how to ask a specific question. So I like that the guidelines kind of pulled out some specific questions so that we can get a really good sexual history for patients to guide, are you at high risk? Should we be considering things like PrEP, for example, to decrease the spread of HIV? But I don't specifically talk about PrEP in this presentation since it's not covered in the CDC guidelines. This is just the reference that most of this data is going to be taken from. And I have one slide of notable changes to the guidelines here. I'm not going to touch on each of these, but there are some things that I want to kind of call out. The updated treatment recommendations, I'm going to spend the next several slides kind of going through what those updated treatment recommendations look like. One thing I want to call out specifically is this sites of sexual activity that the patients or people that we're working with are engaged in. And so there are some new tests that specifically test for rectal and pharyngeal chlamydia and gonorrhea. The problem with rectal and pharyngeal chlamydia and gonorrhea is that a lot of times they can be asymptomatic, but still be spreading to other people. So making sure that you're getting a sexual history and you're testing the sites that a particular patient engages during sexual activity. In the last decade, the rates of congenital syphilis transmission from mom to baby have increased by more than 500%. And so with that, we want to decrease the rates of congenital syphilis. And so the CDC has kind of, again, came in line with some other recommendations to increase the number of times we test patients. So at a minimum, it should be at the very first prenatal visit, whenever a patient has become pregnant, we should be testing for chlamydia, and then again at 28 weeks. Right before delivery, if it's a patient that's at high risk, maybe multiple sexual partners, IV drug users, those patients should get a third test for syphilis right before delivery. Harmonize the HPV vaccination stuff. I've already talked a little bit about that. And then recommended universal Hep C screening. So before it used to just be patients born before 1960, 1965. And now they've expanded that to say any adult patient over 18 should really be considered for Hep C testing at least once in their lifetime, and then more frequent testing or yearly testing if they are in a high risk category. Again, IV drug users or multiple sexual partners. Okay, so let's get into the specific disease states that we're going to be talking about. Syphilis, affectionately nicknamed the Great Imitator, and it's partially because it presents in a lot of different ways. After first exposure to syphilis, it'll kind of appear as this hard nodule. Most patients say that it's not painful, and a lot of patients don't even realize it happened. And after about 2 to 8 weeks, that'll kind of resolve, and then you'll move into some of these secondary syphilis symptoms. So that's rash, which is typically on the hands and the feet. It's kind of like a reddish brown color rash. It's not locally, it could be more disseminated than just the hands, or it might not be on the hands at all. So while it does present frequently on the hands and feet, it could just appear as patchy body rashes as well. Alopecia, and then mucus patches. All of these symptoms resolve. So there's a very good chance, most of the time, patients will present in the secondary syphilis zone. And so we need to get those patients treated. But a lot of times, because some of the effects of syphilis can be really kind of minor, just kind of more quality of life things, sometimes they might not actually get treated, which could lead to the more severe tertiary or late syphilis. And so these are the ones, this is, King Henry VIII famously died from neurosyphilis after the disease itself caused him to go crazy. So treatment. What is treatment? Penicillin, one of our very first antibiotics that we've ever used, and still to this day, mainstay of therapy for treating syphilis. So it is specifically the long-acting version because it is given as a one-time dose. So the benzathine penicillin G at 2.4 million units, one single IM injection, and we're good to go from there. The problem is in the US, we have a high rate of patients that are penicillin allergic. And so we do have some alternative options here. There are 2 patient groups that, despite penicillin allergy, we should really consider still using penicillin in, and that's patients with HIV infection or pregnant patients. So in those 2 patient populations, the CDC actually recommends doing a desensitization to penicillin, and then finally administering the benzathine penicillin G injection, IM, for them after you've desensitized them. So those two treatment categories tend to not be treated as effectively with some of these other medications, and we want to make sure that we're eradicating syphilis. One comment here, though, azithromycin. This is something that we've actually used as a mainstay historically for syphilis, but really the guidelines strongly encourage against it now because of the rates of resistance are so high with using azithromycin, even at the higher dose. So there was a thought, well, yeah, let's not use the 1 gram, let's use the 2 gram and see if that knocks it out. But really the resistance rates make it not worth using. In early syphilis treatment, they're likely to get this kind of systemic reaction. It usually happens very soon after starting therapy, after the IM injection of penicillin. And it's more common in people that you happen to catch in that primary or secondary syphilis, because at that time, the rates of bacterial turnover are higher. And so you're more likely to have this kind of systemic reaction, fever, chills, headaches, and the lesion exacerbations potentially as well. Recommendation, just treat with antipyretics, Tylenol, ibuprofen. You can add antihistamine to that as well, but really it's just symptomatic care. It's more important to tell patients that this is likely to happen and kind of watch for it, and so they know how to treat it, and that'll avoid you getting a call about it later on. Okay, so what about late latent syphilis? And so they break it down into either early latent syphilis or late latent syphilis, and that's the dividing time that they use for that is a year. So less than a year, if you know that the patient's had it less than a year, maybe they had a syphilis test 9 months ago that was negative, and now they have a positive. In those patients, you can treat them just the same in those early latent syphilis cases, treat them just the same as if it was the primary presentation. However, if you're not sure whether or not it's been in the last year or if it's been over a year, the recommendation is just to treat them as if they've had it more than a year. So they fall into this second category, the latent syphilis. Essentially, the only change, it's the same dose, the same injection that they're going to be getting, except they should get 3 injections weekly for cure. And syphilis is one of the STIs that we really should make sure we're doing a test of cure. You can do a test of cure in these patients 6 months after, get those titers, and you want to make sure that those titers are coming down to show that syphilis has been adequately treated. Again, there's alternative therapies. The big thing here is that it's extended. So instead of the shorter duration, you really need to treat for pretty much an entire month. Okay, what about gonorrhea? This is a very common STI in the US. This is diplococci, possible symptoms. A lot of times these are symptomatic. So patients often will have kind of a white discharge, burning with urination, the classic UTI or the classic STI symptoms. Treatment for this has also changed. Ceftriaxone is our tried and true for the treatment of gonorrhea. The biggest change, though, is the dosing. And so historically, we've used ceftriaxone, a dose of 125 milligrams IM once, and that will eradicate. However, we are seeing higher rates of resistance. And so the CDC actually settled on a dose of 500. They made a comment in the guideline, though, that a dose of 250 is enough to eradicate in 99% of patients. The reason that instead of settling on the 250 and recommended at 500 instead is to, 1, ensure that it's eradicated, and 2, hopefully decrease the pattern of increasing resistance by really hitting it with a hard dose to decrease the likelihood of that resistance. So ceftriaxone dose definitely increased compared to what we're used to. And then same thing with cefixime, which is our oral option. Most of the time patients are in clinic, they're just gonna get the IM injection. We know that they got it, and then they can go about their business. If we are prescribing the oral options, maybe for a partner who we might not be seeing physically there, so we can't actually do the IM injection, but still need to get them something to eradicate, we could consider using cefixime. Again, you'll see here, avoiding fluoroquinolones. While they do have some treatment efficacy, the likelihood of resistance with fluoroquinolones are very high. And so really that recommendation is to avoid using fluoroquinolones for gonorrhea treatment. And then there's a statement here. So if chlamydial infection has not been excluded, we'll talk about this. I think chlamydia is the next thing we talk about, but you'll see here doxycycline. This might be a little bit of a change from what we might have in our minds as far as the treatment of chlamydia. Because typically we do azithromycin, or historically we have done azithromycin. So chlamydia is one of the most frequently reported STDs in the US. A lot of patients can present without symptoms though. And the stat that I used here is 50, but I've seen, and depending on what literature you're looking at, that rate of asymptomatic infection can be as high as 75%. So if patients coming in complaining of UTI type symptoms, but urine is sterile, it might be worth considering chlamydia and doing just a full STI panel, especially if it's a patient who's at risk due to a new sexual partner or multiple sexual partners. So chlamydia treatment, already alluded to this, but doxycycline, it gets the recommended dosing. There's higher cure rates with doxycycline. This is in both men and women. However, if you really look at the data, men tend to need to be treated with doxycycline for eradication, whereas women, you might be able to get by with just using the azithromycin 1 gram dose. However, again, guideline recommendation is doxycycline BID for 7 days. The exception, they make a very clear delineation. If you're worried about adherence, it is an entire week. It is something that you take twice a day. And the longer we have people take something and the more times a day we have them take something, the less adherent they are going to be to therapy. And so that's a good conversation that we should be having with our patients. Do you really, truly, do you think it's feasible for you to be consistently getting this twice a day for the next 7 days? If not, we might lean towards using the azithromycin dose, 1 gram dose instead. Levofloxacin you can use for chlamydia. Because of the, a lot of times chlamydial infections are coinciding with gonorrhea infections, I'd really lean away from fluoroquinolones for treating sexually transmitted infections. But it is a treatment option, especially if you know that the patient only has chlamydia. You can use levofloxacin for 7 days. Genital herpes, presents as blisters. It's kind of recurrent. This isn't something that we can, that's not going to be cured, but we can make it better. I saw a question in the back. Yeah.
So I'm looking here at partners that you can't.
Mm-hmm. Yeah, so, okay. Clarifying here. So you said using the azithromycin, you could treat both the gonorrhea plus the chlamydia. And you're saying for partners that may not be physically present, what's partner meds? Yeah, prescribing the PO options instead of the IM because they're not physically there. So the problem with that is that if you're using azithromycin here, it actually has this plus. So this isn't by itself. So azithromycin monotherapy is not good enough to treat gonorrhea. And so you need to either combine it with gentamicin and azithromycin or just ceftriaxone alone. Does that answer your question? Okay, cool. Yeah, these are together, so you can't separate them. Cefixime, though, could be monotherapy as an oral option. Again, if you don't know, you'd still want to combine that with either the doxycycline or azithromycin to treat any concomitant chlamydia. So it's usually, gonorrhea is almost always going to be a 2-med treatment. Okay, so genital herpes, spreading of genital herpes is usually during breakouts. So when, not only is it the blisters themselves are painful, but whenever they're present, you have the viral shedding, which is where you're going to get the infecting of partners. What's worse is whenever those blisters rupture, they kind of leave open sores, which can be really painful. And so the key to treating genital herpes is really, as soon as patients start experiencing the symptoms or the outbreak coming on, we need to get an antiviral on board ASAP to worsen that particular episode. So lots of treatment options here. This left-hand chart is for the very first presentation of HSV-2, and the second chart is for patients that have recurrent HSV-2 outbreaks. And a lot of times, for the recurrence, a lot of times providers will make it available to patients so that they don't have to call in. So kind of having a PRN prescription at the pharmacy for whenever patients do have outbreaks. That way you don't get a call on a Friday afternoon with a patient kind of up in arms about the fact that they don't have any meds to treat their HSV outbreak, and we might not see it until the following Monday, right? We really don't want that patient to go that weekend. So hopefully giving them something to prevent or treat future outbreaks. Dosing here is, there's not a lot changed from HSV treatment. My clinical practice or my clinical recommendations for treating HSV is that whatever has the lowest number of administrations per day and the least number of days. So a lot of times that ends up being valacyclovir. Valacyclovir, you might run into insurance issues, in which case I'll tend to lean towards acyclovir, but I really try to be as patient-centric as possible and decrease how often they need to take meds for this. A more common question that I get in clinic clinical practice is, what do I do with somebody who has recurrent infections? At what point do I need to consider a suppressive therapy for patients? And so the guidelines say suppressive therapy might be beneficial for patients that have more than 4 or 5 outbreaks per year. And so in which case you'd choose one of these. Again, I tend to lead towards valacyclovir just because it's easier for patients. It's once a day for however long they want to be on suppressive therapy. I tend to lean towards, try to minimize the dosing. So most of the time I'm recommending the 500 milligram. However, you can see this caveat here. If a patient has really frequent occurrences or outbreaks, at which they define as more than 10 per year, really the lower doses may not be as effective. So you really might push the higher dose in those patients. One of the benefits about suppressive therapy is that there's partners who are HSV2 negative. They're less likely to seroconvert to being positive in patients that are being treated when their partners who have HSV2 are treated with suppressive therapy. So if you have discordant couple, using suppressive therapy in the positive partner will decrease transmission. I saw a question in the back. So the question was seeing valacyclovir 2 grams every 12 hours for 2 doses. I did not come across that whenever I was putting this together. I could see the argument, especially if you're hitting it really hard up front. I worry about that dose being super high though. So the likelihood of tolerating, I would question. But as far as from preparing for this presentation, that's not something that came across as something that has enough clinical evidence to really kind of include it in the guidelines. So good question, thanks. Okay. And then the last one here is not actually, well, it's an infection, but it's caused by a parasite. This is another hard one because most patients are asymptomatic. Up to 70% of people end up not having symptoms for this. So again, if you're having somebody in that's complaining of typical UTI symptoms, but their urine is sterile, it might be worth checking and or just treating for this, especially if there's like a history of infection. So this is another one where the doses for guys and girls tend to differ a little bit. And I think it's mostly out of just what's been studied. So we used to do this higher dose, 2 grams as a single dose for both men and women. But there was a study, I think in 2017, that looked at women specifically. So the study totally excluded men. But in women, they found that the metronidazole 500 BID for 7 days was superior for eradication compared to the high dose once. Again, it's a conversation of can you adhere to this for that time period? If not, maybe just leaning towards the one-time dose, even for women. But knowing if they fail that one-time dose, it's worth kind of going back and doing the low dose for an extended period of time. And then if they fail that, then going to the tinidazole. One of my key points is get tested. All adults should be tested for sexually transmitted infections. Talked about here, including HIV, at least once in their lifetime. For patients with a couple of sexual partners per year, you might want to at least do yearly testing. So anything more than around 2 or 3 sexual partners per year, I'd still recommend at least yearly testing. Anything more than that should be tested more often, at least every 6 months, potentially every 3 months, depending on, again, how many partners they have. And quick summary slide here. So I think there's a question that I had. And I was trying to use my phone to watch this, but. Okay, I think it's open. Which of these should not be used? Okay, and it says azithromycin. Great, good job. That is correct. Okay, so moving on. Uh-oh, My pointer messed up again. Okay, so moving on, we're going to be talking about GERD. Where's my time? Okay, perfect. So GERD, learning objectives here, signs and symptoms. So this is, I think this guideline was published online in October and then published early this year for the print version. So a lot of the citation here is the American Academy of Gastroenterology is where these GERD guidelines are coming from. And so a big thing that they push in this is identifying patients at risk for more severe things when GERD isn't really GERD. So GERD might be things like H. pylori infection, or GERD might be peptic ulcer disease. And so in an effort to kind of capture those patients earlier, they recommend anybody that presents with any of these alarm symptoms, so trouble swallowing, cough, difficulty breathing, kind of the extra esophageal symptoms, or affecting words or ability to swallow, all of those patients should maybe be considered directly going to an EGD to kind of scope the stomach, see what's going on down there, and see if a patient might have H. pylori infection or something more insidious happening. And so that's a big shift. EGD is, in this guideline, is a much heavier emphasis than we've had in previous versions. Key symptoms though, heartburn, epigastric area sometimes radiating up. It sometimes can radiate around the back in an atypical presentation. And then regurgitation. So patients belch and they kind of have that acidic or metallic taste in their mouth. So those are things, that's the classic signs of GERD. And so if it's just those things without any of these alarm symptoms, what do we treat with? And so we'll talk about that. First thing, as always, should always be lifestyle education and lifestyle changes. Patients that come in only having heartburn symptoms once a week really should be identifying the things that are likely to cause them to have heartburn and then avoiding them, or at least decreasing their consumption of those things. And usually it's two different mechanisms that are kind of playing into people having GERD-like symptoms. One is this lower esophageal sphincter. So this is the sphincter that separates our stomach from our esophagus. Ooh, sorry. And so there's some things that we eat. Oftentimes, chocolate, mint, and coffee, those are really common after meal things for us to kind of indulge in. And all of them are actually really not good from a heartburn or reflux standpoint. So trying to encourage patients away from these things, especially if chocolate is the thing that causes you to have GERD. Thank goodness it doesn't cause me to have GERD because I love chocolate. But it might be difficult for patients to adhere to some of these things, especially if it's something that they really enjoy. The other component is increased stomach acid. So not only do you have the sphincter that should be closed tight enough to prevent kind of that regurgitation and contents of the stomach going into the esophagus, but also the lower your pH of your stomach is, the more likely you are to have those symptoms and have that regurgitation. And so avoiding foods that specifically kind of increase that stomach acid. So acidic foods, citrus juice, tomatoes is a common one. And then finally, there's some other lifestyle recommendations. Obviously, tobacco cessation can kind of lower esophageal sphincter tone. And so that will increase the likelihood of regurgitation. Weight loss, if you have more intra-abdominal pressure pushing onto your stomach, again, the contents of the stomach have to go somewhere. If you have a lot of intra-abdominal pressure, most common place is up. And then elevating the head of bed, especially if patients have trouble sleeping or they wake up frequently in the morning with kind of a sore throat related to their GERD symptoms. Okay, so lifestyle is critical, but at some point we might need to consider pharmacologic therapies. And there's two schools of thought, very similar to what we see in things like the statin conversation, right? Do we start at a low dose, increase? In the statins, sounds like we should start with a high dose and then decrease based on tolerability. And so the new gastroenterology guidelines would agree with a step-down approach. So gastroenterology guidelines do say PPIs are the most effective thing that we have for treating GERD. We need to lean on them as the first line therapy. Where I would say using the step-up approach might be more appropriate is in those patients having symptoms only once a week. If it's not daily symptoms, do we really want to give them a chronic medication just for the occasional symptoms? Probably not. So in patients that are infrequent, once, twice, 3 times a week having symptoms, trying to avoid their triggers is critical. But also giving them antacids or an H2 blocker, which both of those can be used a little bit more as needed with good effect. Whereas PPIs, really you need them on board for a couple days to really see the full effect of PPIs. But ACG says step down approach, start with PPIs. Actually, the guidelines don't really talk too terribly much about H2 blockers or antacids. They lean very, very heavily on PPIs. So here's their algorithm that they came up with. Again, heartburn without those symptoms of, without those alarm symptoms is the patients that kind of follow this guideline or this particular algorithm. And so they say 8 weeks of PPI. They specifically say make sure to take your, they specifically say to make sure to take your PPI before a meal. They showed that first thing in the morning before breakfast is going to give you much more acid lowering and symptom relief than doing maybe your PPI daily at nighttime. So timing does matter. Really, before your first meal of the day is going to be best. After that 8 weeks, they say, now let's discontinue the PPI and see if those symptoms recur. If symptoms recur, maybe we should, especially with doing lifestyle changes, maybe we should consider doing an EGD. It's important to hold the PPI for a couple of weeks, at least 2, ideally 4. That way, whenever they do the EGD, there's less likely to be confounding factors there that could influence the outcome of that study. So what if we had a patient on 8 weeks of PPI but didn't have complete relief? Well, they say go ahead and stop the PPI 2 to 4 weeks and then do that EGD study. Okay, so let's talk a little bit about PPIs. One of the side effects that you want to be cognizant of with PPIs is this idea of kind of whenever we discontinue the PPI and then we have sudden onset of worsening symptoms of reflux, right? The guidelines actually question whether or not that's actually true. We do have data, some data that shows sudden discontinuation of PPI is more likely to result in kind of a spike in symptoms. But the guidelines say there's not really enough data to say that that's for sure happening. So they don't really lean too far on, do we do a taper down or do we just stop cold turkey? They kind of just say stop cold turkey. But I have another slide that kind of talks a little bit about that. But the idea is that in people with chronic PPI use has an upregulation of these proton pumps in their stomach, that when you suddenly stop PPIs altogether, because of the upregulation of those receptors or those pumps in the stomach, now you have even more acid there. So the jury's out. We will see, but anecdotally, I've had lots and lots of patients fail just abrupt discontinuation of PPIs, especially on higher doses. And so I lean towards the side of let's taper off. That's my personal bias. And then we'll talk a little bit more about how to taper off if you choose to do that. Some key points here from the guidelines. So switching agents is not likely to result in improved response. We have this idea that, well, if you fail a Protonics, then we can try omeprazole. And if you fail omeprazole, we can try one of the others. And really the guidelines say there's no data that says one is more effective than the other, and that switching process doesn't really do much. What does do better is dose escalation. And so, instead of, I think the second point here is twice daily dosing is superior to once a day dose of the higher dose. So if you have a patient on omeprazole 20, fail therapies, still want something to help get their symptoms under control, it's better to do omeprazole 20 BID than doing omeprazole 40 once in the morning. And so guidelines would encourage us to use BID dosing before using the high single dose, just from an efficacy standpoint. And then you could technically increase to the high dose twice a day if they continue to fail. But at that point, they should probably already have an EGD set up so that we can see if there's something more insidious happening. And again, make sure we're off of PPIs for 2 to 4 weeks before that. This is another area of contention in the guidelines because we have a wealth of knowledge. Granted, they're smaller studies that look at the efficacy of, or excuse me, the side effects. And so the guidelines kind of fall on okay, thanks. The side effects are really not as significant as a lot of this research that we've done, these small studies are showing it to be. And so the one that they specifically called out, there is an overwhelming wealth of evidence to show that PPIs do affect something. It's the rates of GI infections, essentially. So GI infections have enough wealth of data for the guidelines to say, yep, prolonged PPI use can increase your risk of some kind of GI infection. C. diff being one of them. But if you look at the number needed to harm for some of these things, they're quite low, which means you are really likely to get some of these things. Despite vitamin D deficiency being a big potential issue, guidelines say the data's not really there, so we don't recommend routine screening for B12 deficiency. However, if you have a patient that's showing up with maybe symptoms of peripheral neuropathy and they've been on a PPI for more than a year or two, it might kind of lean you to think, maybe this isn't actual neuropathy, maybe this is B12 deficiency. So something to kind of dive into a little bit more with your patients if they have some of these side effects. But a whole host of side effects are in the literature, but the one that has the data to truly support it is those GI infections. Another big question is, what do we do with PPIs in patients taking Plavix? Because Plavix is an inactive drug that is metabolized by 2C19 into its active metabolite or its active form. So if you shut this down and you don't have conversion into the active metabolite, you get failure of Plavix in those patients and increased risk of CV events. The data to show that PPIs increase the risk of CV events is not great. The theory behind this is great, but the numbers aren't quite there. So what I do, omeprazole has more CYP interactions. So omeprazole is the one I definitely avoid in patients that take Plavix. I usually lean towards pantoprazole in those patients. We have more data in pantoprazole to show that it doesn't affect Plavix efficacy. So just a caveat, just something to think about because this question comes up a lot. Can we use PPIs in patients with Plavix? Yes, I'd be cautious. And maybe try to avoid it in patients that have really high ASCVD risk or have had recurrent heart attacks or strokes. So my thoughts there. And this is something, baseline characteristics could kind of lean whether or not Plavix at baseline is even effective. So in patients that are poor metabolizers, specifically, you see Asian populations tend to have be lower on the metabolism side for this particular enzyme. And so it might be worth avoiding specifically PPIs in that group just because they're already at higher risk for failure to Plavix. Okay, duration of therapy, talked about this already. So I think a lot of this is summary. 8 weeks, trial off of therapy. If they have symptoms recur, consider EGD, make sure they're off for 2 to 4 weeks before we do the EGD to get a good study. And then patients presenting with extra esophageal symptoms. So this is the kind of the regurgitation up to the throat, burning in throat, hoarseness, dysphagia, trouble swallowing. So those patients should be evaluated by EGD to see if there's anything insidious happening in the stomach that can be contributing to those symptoms. But in the meantime, because I doubt you're going to be able to see a patient and then immediately have them scheduled for an EGD, right? So it might be worth still giving them some therapy and making sure that they stop it enough in advance for the study. But the duration can be longer in those patients. And the second thing is the twice daily dosing. Again, because those symptoms are so significant and the quality of life affects those patients so much, using twice a day for that added efficacy for up to 12 weeks is the recommendation. And who gets lifelong therapy? Patients with, after the EGD will be able to show you what level of esophagitis they have. And so patients with those higher grade C and D, the recommendation is that you might need to consider PPIs for life in those patients. Okay, so deprescribing. I'm not going to spend a ton of time here. Essentially, my practice with deprescribing is if they are on a high dose, I will reduce to the low dose. If they're on twice a day, I will reduce to once a day. And so slowly just kind of stepping back what their PPI dose is, give them about a week and a half, 2 weeks maybe in between each of those dose changes. Again, and that's the idea behind that, is to allow their stomach and those up regulation of those proton pumps to down regulate as we pull back the PPI. And then when they get down to the lowest dose just once a day, I'll frequently do every other day dosing for another week and then stop it and see how they do. So you should not get somebody off of a PPI if they have one of these diagnoses down here at the bottom. So these are some of our lifelong indications for PPI use. H2 blockers, because the guidelines don't talk about them too much, I'm not going to either. One thing that I do want to say is don't use cimetidine. It has far more drug interactions than any of the others in this class. And I see this is a recommendation I make all the time for patients coming in on cimetidine. Let's get them off of that. Too many drug interactions to warrant continuing. And this statement is not very true. I realize after the slides were into you guys, really in somebody with ulcer disease, you should be on a PPI. There's really no role for H2 blockers anymore in that patient group. Side effects, these are renally cleared, so be cautious of accumulation. Particularly in accumulation, you can get more confusion or altered mental status. And so patients that are presenting to the ER with altered mental status in AKI and are on H2 blockers, it might be worth stopping that H2 blocker before they are discharged. And then over-the-counter stuff, really the place in therapy should be patients with sporadic episodes of reflux, or whenever they know they're going to eat that thing that always causes them to have heartburn. Go ahead and pre-treating with an antacid in those patients. Other pharmacotherapy, sucralfate really has too many drug interactions. It works very effectively. Kind of the only place in therapy, the guidelines specifically call out pregnancy potentially. In pregnancy, a lot of the PPIs are category B. The exception is omeprazole is category C. So if you're using a PPI in pregnancy, really lean towards anything but omeprazole. All H2 blockers are category B, but still the guidelines kind of pull out using sucralfate for pregnancy. A lot of times those patients aren't on as many chronic medications, so maybe you're not running into that issue as much. But a lot of times it's poorly tolerated too. So it's not something that I will necessarily lean towards, but in pregnancy, that's kind of where you might see this used most commonly. And misoprostol is really for just GI bleeding. It could be used for GERD type symptoms, but it's too heavy hitter for what we're doing. And the other scenario for chronic PPIs outside of the stuff that we've mentioned already is patients that need chronic NSAID therapy for things like osteoarthritis, maybe they're on chronic NSAID use. And so maybe consider PPIs chronically if they are in one of these two higher risk categories. So history of GI bleed is a big one, or if they're on multiple like anticoagulants or antiplatelets and that bleeding risk is too high. And then keep in mind patients over 60 are going to be at higher risk. So if they're over 60 and have any other risk factors, again, lean towards using PPI almost as a prophylactic medication to decrease the risk of ulceration. And then just avoid these piroxicam, ketorolac, and indomethacin have some of the highest GI bleed risk. So staying away from those, or if patients are currently taking those, really lean towards getting them on prophylactic PPI. But I would argue to drop the risk of the GI bleed, then add on one additional medication to decrease the GI bleed risk. Okay, so I think I have a question. Okay, if I stop my PPI, if I stop by PPI, cold turkey, I will have rebound and more intense acid production. Oh, I didn't realize it wasn't projecting up there. Okay. I am alt tabbed, but it's still not, it's fine. Okay, nope. Yeah, people can see it on your phones. And so this one is pretty evenly divided. 16 says true, 30 says false. It's whatever you want it to be, actually, because the data doesn't actually support that being a thing. However, I have overwhelming anecdotal evidence that says it is a thing. So my personal stance is, yes, that's a thing, but guidelines disagree. Okay, here's my 10 minutes for diabetes. There's not a lot in this update, so I'm actually going to go through this section kind of quickly and pull out some key points. So comprehensive diabetes care, one of the big changes here is, well, the blood pressure goal, we've already talked a little bit about that. It's different guidelines are recommending different things. For most of my patients, I say if we can get down to that 130/80, that's going to be better. We have good data to show that better controlled blood pressure equates to better quality of life long term. However, patients that frequently get hypotensive down that low, maybe we can kind of back off a little bit on that recommendation. And then lipid goals, we've already talked about. Moderate intensity statin for most of these patients. If they have high ASCVD risk, you'd consider that high intensity. One of the key points here, though, is this select medications based on comorbidities. So historically, we've had metformin as our first line, right? And so they've kind of downranked metformin a little bit, especially in patients that do have things like existing ASCVD, existing CKD, or existing heart failure. And so we'll talk about that on a couple slides here. Make sure we're using our CDEs, our nutritionists. They are an integral part. And so these are the 4 stages in diabetes care, essentially, that we should be considering for a referral to a diabetes educator. I'm not going to spend too much time there. That's not new. It's just kind of a reinforcement of what they've already updated and previously. I get a question a lot about what general dietary education do we need to be providing these patients. And so plate method, we talk about this all the time in clinic. If a circular plate, half of that plate needs to be filled with some kind of non-starchy vegetable. A quarter of that plate should be a protein, and a quarter of that plate should be a complex carb, ideally. And so I spend a lot of time just talking about that idea and make sure, again, the plate method should be such that you see some of your plate, right? You don't want to have food just piled on to the point where you don't see any of your plate. There needs to be some white areas on that plate so that it's not filled to the brim. A good carb intake per meal, 40 to 60. For women, usually on that 40 to 50 side. For men, closer to that 50 to 60 side. Kind of their body habitus will kind of delineate this a little bit. Muscle mass, but somewhere in that range is good. It's really important not to go above that if you can. But if you're under it, that's fine. 20, 30 grams of carbs per meal is a good goal to shoot for too. Most of my patients aren't able to adhere to that. So we tend to push these upper limits with some of my patients just for their own quality of life. Making sure we're getting dietary fiber that's going to slow down how quickly our stomach will empty and therefore will decrease that postprandial spike that patients have. Another good recommendation is when you're sitting down to eat, instead of going directly to those mashed potatoes, maybe start with the broccoli. Start with the thing that's going to kind of fill you up. It's going to give you that fiber so that by the time you get to the mashed potatoes, again, it's not going to, if mashed potatoes are first, it's going to cause a huge spike immediately and then quickly decline. Whereas the non-starchy vegetable first they're still going to get the same exposure to the carbs, but instead of having a really high spike in their blood sugar, it's going to be more gradual. And then obviously sugar sweetened beverages are the absolute worst from a diabetes control standpoint. So any amount that we can decrease there is going to pay in dividends. A1C goals, this is not different, but be thinking about patients that the standard A1C goal of less than 7 isn't appropriate. The most common scenario in my clinical practice for decreasing or increasing the goal up to 8% is kind of all centered around hypoglycemia risk. Are they having recurrent hypoglycemia? Are they having hypoglycemia, really severe episodes of hypoglycemia? Or maybe their cognitive function isn't such that they can either identify when they're low or treat when they are feeling low. So those are some scenarios where I'm going to be reducing those goals. Okay, I alluded to this already, but this top line here again says lots of things should be considered whenever you're developing a medication therapy for these patients, which generally includes metformin. That's a big change in language, whereas before it was said, must start with metformin, right? But now there's this recognition that, well, if a patient has ASCVD or really high ASCVD risk, why would I start something that does, while it does have some ASCVD risk reduction, it's not clearly as robust as things like GLPs or SGLT2s. So metformin kind of gets downgraded, still is one of the top things we would recommend, especially if they don't have any other comorbidities. But if they do, so if they have ASCVD, we should really be leaning towards a GLP or an SGLT2. Although the data with GLPs tend to be a little bit better in that patient population. I might kind of change up if they have ASCVD plus heart failure, so it puts them in two of these categories. In that scenario, I might lean towards SGLT2 first, just because we're going to hit 2 indications. And if they need additional lowering after that, then I can maybe come back and add a GLP-1 after the fact. And then CKD is the other big risk category here. So if they have CKD, especially with albuminuria, which kind of touches back to Stephen's recommendation to make sure that we're getting microalbumin to creatinine ratios for these patients. But if that number comes out being above 200, there's a very clear indication for SGLT2s in those patients as well. There's some data for GLP-1s from a renal benefit, but it's not nearly as robust as the data that we see with SGLT2s. So SGLT2s kind of get first line for heart failure and CKD. GLP-1s tend to get prioritization for ASCVD. And then if they don't have any of those, then you can kind of do whatever you want, kind of talk with the patient, see what kind of resonates with them, and then go from there. Okay, so one patient case. I'm going to just talk about this real quick. 47-year-old patient with type 2 diabetes, dyslipidemia, CAD, hypertension, currently taking metformin monotherapy. He is a recovered alcoholic, sober since an admission to the ER 8 years ago for alcohol-induced pancreatitis. It's historically worked well for him, but he's noticed his blood sugar is trending up. His fastings are 120 to 140, which is pretty good, but he's having a pretty good spikes in his post-meal numbers. So you can see his postprandials are closer to 192 to 230, and his goal is less than 180 for those numbers. And so, whereas the fasting, we're shooting for 80 to 130. So those are okay, but we can definitely have some improvement here with the dinner levels. Considering he has CAD, I would immediately think, okay, maybe a GLP-1 or an SGLT2, but you have this history of pancreatitis. And so there's a warning with GLP-1s that they can induce pancreatitis. And so if it's somebody with chronic pancreatitis or recurrent pancreatitis, I definitely I would steer away from them. But this guy's risk factor for developing pancreatitis is related to something that he no longer does. And so his risk is going to be a little bit lower. So I would actually consider using a GLP-1 in this patient and just have him kind of watch out for any risks of pancreatitis. Okay, so GLP-1s, I'm going to hit the highlights here. And so very beneficial from ASCVD, obviously. Also weight benefit. I've had lots of patients be able to lose 15, 20 pounds with using GLP-1s. And what's so beneficial about that, especially in type 2, is that we know excess weight tends to promote higher insulin resistance. Higher insulin resistance tends to promote the need for more insulin, which can lead to more weight gain. And so it's a cycle that's kind of never ending almost. And GLP-1s is a great step in the direction to avoid that cycle that we get stuck in with excessive weight gain with a lot of the meds that we use for treatment of diabetes. Some things that we want to avoid: gastroparesis, just by way of how it works. It's kind of, the med actually causes, it's almost med-induced gastroparesis, how GLP-1s work. Slows down the stomach's emptying, makes you feel really full. And those are two of the things that people with gastroparesis already struggle with. And so it's not an absolute contraindication, but it's definitely something that we should keep in mind. Somebody that has baseline nausea, vomiting, this class of medications may not be the best for them. And if we are going to use them in those patients, I'd recommend not titrating up to those highest doses. DPP-4s, half as effective as GLP-1s, also much more tolerated. You want to be cautious in heart failure and in patients with pancreatitis or gastroparesis for the exact same reasons for these top two as we saw with GLP-1s. Heart failure is kind of mixed data right now. There's Januvia is the only one. Januvia and alogliptin have both shown to be kind of neutral from a heart failure risk standpoint, whereas saxagliptin was shown to actually increase heart failure risk or admissions for heart failure. So saxagliptin, definitely avoid, but you might be able to get by with the others. Just be cautious with it. Where I see this most commonly, or where I use this most commonly, is patients that have just don't tolerate stuff in general. This is one that most patients, there's very few patients that have ever started on this that have a negative side effect that's worthy of discontinuation. And SGLT2s, biggest thing that we haven't talked about already is the recurrent UTIs or yeast infections. The guidelines say as long as they have heart failure, CKD, or ASCVD, the benefit outweighs the risk. But I put that on the patient and ask them what benefit risk ratio they're willing to put up with. Do you want this medication that's going to reduce your risk of heart attack, heart failure, CKD progression, but at the expense of potentially recurrent urinary tract infections? The biggest thing that we can do is proper education to decrease this risk. So for women, whenever they're wiping, make sure they're wiping front to back, proper hygiene, making sure underwear stays dry, and this is for both men and women. So if they're soiled or wet, you don't want that wetness to stay in contact because it's going to increase their risk. And then specifically for men, I've not had as many issues or side effects with the men started on this. However, uncircumcised men are at higher risk. So making sure uncircumcised men are pulling foreskin back and cleaning appropriately is super important to decrease this risk, because it's the thing I see most. Okay, and I'm over time. So there's 2 slides on insulin initiation. Take home here is if they have a history, or if they're to the point of needing an injectable therapy, the guidelines strongly encourage using a GLP-1 first. And again, it's for those metabolic concerns that I've already alluded to. However, if we are starting insulin, I really like the guidelines that they use here. Start at 10 units a day, or this weight-based dosing, and then giving the patient the power to kind of do their own self-titration. 2 units every 3 days if their fasting blood sugars continue to be above goal. It's a really great way for us to empower our patients to kind of take their management into their own hands. And the next couple of slides will just talk about how helpful diabetes technology can be in managing patients. There's a big focus with the guidelines on using diabetes technology. I've included criteria if you have anybody that you're thinking might qualify. This is some of the insurance-based criteria, or some things that you want to make sure that's in your chart notes to help get those things approved. And with this change to focusing on diabetes tech, they've done a better job of saying, what are the parameters we care about, right? So what are we looking for? And I've highlighted the two of the most important at the bottom. Time in range, you want their time in range to be above 70%, and their time below range, you want it to be less than 5%. Again, minimizing the risk of hypoglycemia while getting them in goal as much as you can. And so those numbers kind of correlate to an A1C goal of around 7%. Okay, and then just cases here at the end and a summary with my last question. So what is the most true regarding the updates to the 2022 ADA guidelines? SGLT2s are preferred for ASCVD. First-line therapy depends on comorbidities, meaning metformin may not be first line. GLP-1s are preferred for CKD, and no need to check microalbumin to creatinine ratio. And first-line therapy depends on comorbidities. Awesome. It looks like a couple of you put SGLT2s are preferred for ASCVD. I would say, yes, they do fall into that category, but really GLP-1 should probably be the first one if you're going from an ASCVD standpoint. Okay.
The code for the section is peony. Peony. Peony.